Good morning and welcome. Sorry, I'm just sorting out. Good morning and welcome to our second session of the day, which is all about treatment and self-management. My name's Barbara Crossley and I'm a patient from the UK. I've been a member of the Bronchiectasis Patient Advisory Group since 2016, and I'll be introducing the speakers and giving a presentation myself. My co-chair is Dr. Peter Comini, who you might have met in our previous session. Peter, would you like to introduce yourself for those who may not have caught the earlier session?
Thank you, Barbara. I'm Peter de Hoemen. I'm a respiratory physician in Belgium and a bronchiectasis enthusiast, and I'm very happy to be here today and to see the almost 600 participants today, so I'm very thrilled to be here.
Our first speaker is Dr. Josje Altenburg, whose talk's entitled Symptoms and Treatment of Bronchiectasis, Fighting the Vicious Circle. Dr. Altenburg's a pulmonologist based at the Amsterdam University Medical Centers, and she specializes in clinical care of patients with bronchiectasis and other lung conditions. Over to you, Dr. Altenburg.
Yes, thank you so much, Barbara and Peter. I hope everyone can hear and see me properly.
Yes, perfect.
Yeah, you can see my presentation as well?
Yes.
Okay, that's great. Then I'll just quickly continue. I'm going to be talking about symptoms and treatment in bronchiectasis. I only have 15 minutes to cover both subjects, so that's a bit of a challenge. And there are some subjects that I only touch lightly upon. Don't hesitate to ask any questions you have in the chat, and I'll try to answer them afterwards. Yes, this is the outline of my talk. I'll talk about symptoms and treatment, as I said, but I'll start by introducing the vicious circle of bronchiectasis. Dr. Gumina already told you this morning that the vicious circle is a bit old-fashioned. We should be talking about the vicious vortex more likely, but I still love the old-fashioned vicious circle, and I think it gives a lot of insight in the formation of bronchiectasis and the treatment options. So I'll just stick to the circle for this talk. Yes. The vicious circle of bronchiectasis, like I said, is quite an old concept, but I think it's still very useful because it explains the formations of bronchiectasis in a few steps, which are quite easy to understand. It starts with the initial trigger of the formation of bronchiectasis, and this can either be structural airway damage or a disease which causes impaired mucociliary clearance. And structural airway damage may either be caused by diseases like a pneumonia, which causes local damage, but it can also be caused by foreign body aspiration. So when you inhale something by accident, which gets stuck in your airways, and underlying diseases which cause impaired mucociliary clearance would be cystic fibrosis-like diseases, primary ciliary dyskinesia, or other diseases which affect the cilia. And in turn, structural airway damage in itself may cause impaired mucociliary clearance.
Josje, sorry to interrupt you, but we can see your screen is in the mode with your notes as well. I wonder if you could go full presentation mode, just so we can
Als je boven naar weergave instellingen gaat.
Yeah.
Yeah.
Thank you. Sorry for
There you can
interrupting.
click, yeah.
Yeah, thanks a lot. No. This one.
Perfect. Thank you.
Yeah, thank you. So when airways are structurally damaged, they will become filled with sticky mucus, which stays there because the clearance mechanisms are destroyed or are broken. And when airways get filled with mucus, they are very likely to become infected with bacteria, because bacteria like those mucus surroundings. And in turn, bacteria cause an inflammatory response because of their toxic secretions, and because the presence of bacteria gives an activation of the immune system. So inflammation is caused by bacteria, but the inflammation in bronchiectasis is both exaggerated and ineffective in a sense that although there is a lot of inflammation and your body's immune system tries to get rid of the bacteria, it doesn't manage to do so. The bacteria stay in place and the inflammation is there, but it's not effectively targeting the bacteria. And it's exaggerated. So even when there are no or only a small amount of bacteria are present, the inflammatory response will be very much upregulated, very high, which causes additional structural damage to your airways, and so on and so on. And this is the vicious circle of bronchiectasis. The vicious circle of bronchiectasis can also facilitate your thinking about your symptoms. I think a lot of symptoms that many of you with bronchiectasis might have can be explained when thinking about this vicious circle. Of course, one of the most frequently met conditions is the cough either with or without production that many of you may have. And this is caused by the overproduction of phlegm and the fact that the phlegm isn't cleared from your airways. Another very frequently met symptom is dyspnea, and this might be caused by structural airway damage, but also which means that a part of your lung might not function properly, but also because the airflow through your airways might be reduced when they are inflamed and filled with phlegm. A symptom that I hear about very much in my clinic is fatigue, and patients often ask me, why am I so tired even when I'm not exacerbating at the moment? And I really believe that this fatigue is caused by energy loss due to your body, who has to constantly fight this chronic infection and has to suppress the inflammatory response. We also quite frequently see hemoptysis, and this might be caused by damaged airway epithelial because of this infection and inflammation which is present. And chest pain can be a really annoying symptom, and it can be frightening as well because it stops you from breathing normally. It can make you feel dyspneic, and it can make you feel really frightened. And we believe that chest pain has to do with infected parts of your lung, which cause irritation or traction to the pleural membrane. Because as you might know, the lungs itself do not have a very extensive nerve system. So your lungs itself, you won't necessarily feel pain from your lungs themselves, but the membrane which is covering your lungs has a lot of nerves, and a lot of nerves which cause pain when they get irritated. I see many patients in my clinic who feel isolated and alone because they don't know if their symptoms are normal, and they often feel like they are the only ones who are suffering from these types of symptoms. So I wanted to show you the most frequently encountered symptoms in bronchiectasis and show you the numbers of patients who also suffer from these symptoms. For instance, cough. Almost 100% of bronchiectasis patients is suffering from cough. Shortness of breath is also, especially with exertion, is also very common and is present in 70% of patients. And as I said, many patients feel really tired and have problems getting through the day because of their fatigue from bronchiectasis. Hemoptysis, frightening as it is present in 1/3 of patients, and chest pain will be encountered in 1/4 to half of patients. So it's encountered frequently, and you're not alone with these symptoms. Then I'll talk a little bit about treatment. And as Peter already said, treatment of bronchiectasis, as physicians, we try to treat bronchiectasis, we try to fight each and every part of the vicious circle in order to stop the vortex from going round and round. So I'll try to talk a bit about treatment modalities, and I'll couple them to different parts of the vicious circle. For instance, when you are aiming at attacking structural airway damage, there's actually not very much that you can do about the cause, but in some patients, surgery can be an option, especially when bronchiectasis is very local and localized to one of the lobes of the lungs. And if the remaining part of your lungs is strong enough, surgery might be an option in order to get control of symptoms and infections. But this only accounts for a very small part of patients. In addition, pulmonary rehabilitation may help you to get your energy and your strength back, even when your lungs are damaged. When talking about the mucociliary clearance part of your lungs, we talk about mucoactive treatments, and many of you may use them, like nebulized inhaled saline, but also chest clearance techniques, which can be taught by a physiotherapist. In order to treat bacterial infection, and Michael already talked a little bit about that, we use long-term inhaled or oral antibiotics, and of course, in case of an exacerbation, we give shorter courses of antibiotics. And when we think about treating the inflammation part of the vicious circle, not many directed treatments are yet available. I think many of you are taking some kind of macrolide antibiotics, for instance, azithromycin, because it has been shown that even in absence of bacteria, it's very effective in treating chronic symptoms and exacerbations in bronchiectasis. But there's ongoing research in this field, and I think Dr. Chalmers will also be talking a little bit about that later on, because we believe that treating inflammation in bronchiectasis might be key to further clinical improvement. So when and how to treat? I think I should start by saying that the initiation of various treatments and the decision when to start a certain treatment is different for each patient and should really be personalized. And ideally, you should be able to talk with your pulmonologist about which treatment is right for you. Especially when we're talking about mucoactive or inhaled therapies or physiotherapy. These really should suit you as a person, and they should be able to be incorporated in your daily routine. And what is possible for you as a person might not apply to someone else. But there is, of course, based on all scientific results and studies we have been performing in the last years, there is an overview of treatment modalities which are captured in 2 recent guidelines. We have the ERS guideline, which was led by Dr. Eva Polverino. And we have more recently the revision of the BTS guidelines. And of course, each country will have their own guidelines for bronchiectasis in place. And I think all guidelines share a stepwise treatment approach of symptomatic bronchiectasis, where the first step of treatment should always be to treat the underlying cause of bronchiectasis. Dr. Goemine has been talking about the different causes of bronchiectasis. There are many causes like pneumonia or tuberculosis, like post-infectious causes, which cannot be treated anymore. But other causes like immunodeficiency or ABPA can be treated in their own specific way. And this really should be done in order to properly treat your bronchiectasis. Another very important thing is that airway clearance should be optimized, either with inhaled treatment, physiotherapy, workouts, or whatever works for you and clears your airways best. Then, when you still have many symptoms, and especially when you're experiencing many exacerbations on a yearly basis, that's where pharmaceutical or pharmacological treatment steps kicks in. And then there is a choice for inhaled antibiotic treatment or long-time macrolide treatment with azithromycin. They can also be combined, and long-term oral antibiotic treatment can also be targeted in order to treat specific bacteria. And please feel free to ask questions afterwards, but for time's sake, I cannot go into details about this. And just to conclude, during all these steps, it's very important to optimize your general health. So to work out or be active on a regular basis, to use a balanced diet, and Dr. Goemine has been talking about that, to consider pulmonary rehabilitation, and to treat comorbidities, so additional problems that you have which relate to your bronchiectasis. So I realize that this has been a really, really quick overview, but I still hope it has been informative for all of you. And with this, I thank you for your attention, and I'll give you back to the chairs. Thank you.
Thank you, Dr. Altenburg. You've addressed several things that puzzle a lot of us in terms of symptoms and when to seek treatment and what types of treatment there are. So I thank you for presenting such a clear picture. Do put any questions to Dr. Altenburg in the Q&A box. Now we welcome Dr. Arietta Spinou. Dr. Spinou is a specialist respiratory therapist who lectures at King's College, London. She co-leads the ERS task force on airway clearance techniques for bronchiectasis. The title of her talk will ring bells for many of us. Why cough is not enough to clear my chest, and why exercise when I feel exhausted. Thank you, Dr. Spinou.
Thank you very much for having me today. I will share my slides with you first of all. Just a minute.
We can see them, Arietta, if you just put it in presentation mode. Yeah, fantastic.
Okay. Okay. Is it okay now?
Perfect, yes.
Brilliant. So I think that lots of people are going to have questions about airway clearance and exercise in people with bronchiectasis. And my intention is actually to answer two main questions. Why cough is not enough to clear your chest, and why exercise when you feel exhausted. So in my presentation, I'm going to first of all talk about cough in bronchiectasis and about the normal airway clearance in people with healthy lungs. And then I will briefly present the variety of airway clearance techniques we have and talk about exercise and pulmonary rehabilitation. And also I will discuss these areas under the aims of the clinical management of this condition. So what are the aims of all the clinicians when they see people with bronchiectasis? This talk comes after the symptoms that were presented. So of course we want to control the symptoms of people with bronchiectasis, and we want them to feel good, to have a general well-being, and to improve their quality of life. And a way to do that is by reducing the exacerbation frequency. So how often they become unwell and they are going to the hospital or they need to take antibiotics. And we also want to prevent the excessive decline in their lung function as much as we can. So first of all, I would like to ask you, what do you know about respiratory physiotherapy for people with bronchiectasis? And this is a poll that you can vote. Nothing, but I guess respiratory physiotherapy is relevant because of this talk. I have heard about respiratory physiotherapy, but would like to know more. Or I'm confident I know lots of things about respiratory physiotherapy in bronchiectasis. What is your vote? I think I'm quite curious to see the result of this one. Okay, so most of the people have heard about respiratory physiotherapy, but they would like to know more. And we have about 34% who know a lot about respiratory physiotherapy in bronchiectasis. So that's quite promising. Thank you for that. And before I go to the respiratory physiotherapy or airway clearance and exercise in bronchiectasis, I'm going to briefly mention that we know for sure that cough is a big symptom and one of the major symptoms in bronchiectasis. And when we studied patients with bronchiectasis and we compared how frequently they coughed during the 24 hours of the day, we saw that there was a big difference between those who are healthy and those who have bronchiectasis, with those who have bronchiectasis having lots of cough throughout the day. And this actually was related with how well they were feeling in general. So it was related with their quality of life, specific for cough, but also their quality of life overall. So we know that cough is a symptom of bronchiectasis, but it's not only a symptom. And I'm going to tell you more about cough in a minute. But before I do that, I would like to ask you, what do you know about chest clearance in bronchiectasis? So there's a few options there. I cough a lot so I can clear my chest without any techniques. There are specific chest clearance techniques, but I do not practice any. There are specific chest clearance techniques that I practice. I do not have bronchiectasis, but I know about chest clearance, or I do not have bronchiectasis and I do not know about chest clearance. Please vote what is applicable for you. Okay, so lots of people they know about the specific airway clearance techniques and they practice them. It's a bit over half of the participants, and there are people who know about airway clearance but do not practice any, 17%, and some people who do not have bronchiectasis. Thank you. So cough is a symptom, but it's not only a symptom. And I would like to answer the question if cough is enough to clear your chest, because I've met patients who have been coughing throughout the day and they were thinking that this was something that they could use for clearing their chest and that would be adequate for managing their disease. So I'm going to mention the two normal airway clearance mechanisms we have in our lungs. This is the mucociliary escalator, which I'm going to explain in a minute, and cough. So of course everyone knows about cough. It is a protective reflex, And it aims to remove the irritant material or the excessive mucus from the airways. So it's a way to protect our lungs from having any foreign material or any other particles that would damage the tissue. There's a sensory input, so you feel then the urge through the central nervous system. You feel the urge to cough, and then you produce this motor output. So you actually do the movement of coughing. And it's interesting that you can suppress cough or you can mimic it voluntarily. So what are you doing when you're coughing? You first take a really deep breath in, and this is the inspiratory phase of cough. Then you close your glottis. This is the compressive phase when you activate your abdominals, and then you force the air out in the expiratory phase of cough. And you produce, during this forceful expiration, you produce the characteristic sound. And there's different pressures you generate, and through these pressures and through this force of the air through your airways, you can actually get rid of the material or the secretions that has initially irritated you. And we can see that you have a forceful movement of the air, and this creates a turbulent flow. But also what makes cough effective is the intrinsic properties of the lining within your airways. So within our airways, we have a liquid that is within the airways, and it's called airway surface liquid. And on top of this is the mucus. So it's the secretions like we know them. When we have lots of secretions, we actually need to produce the cough. And another thing that I would like you to remember is that you can initiate cough from the biggest, the largest airways. So from the main bronchi, from the trachea and the pharynx. So if you think about the picture that initially you saw from Peter's presentation, where you can see the airways as a tree, which is upside down, then you don't have the smaller branches producing any cough. And this is important to keep in mind, because if you have any material that's irritating your airways at this point, you need to bring it higher so you can actually produce the cough and generate the cough. And if we think about the mucociliary escalator, this is a system we have. These are some tiny cilia, so here, that are within our airways. You can see them here, that they're moving in a specific coordinated fashion to actually bring the secretions higher so they can be swallowed or they can be coughed up. So thinking about the tree, the cilia are again on the generations of the airways that are above this level. So you don't have cilia in the very small airways. And we know that from some animal models as well, where we see that we cannot initiate cough reflex in the small airways, but we only do that from the bronchi and above. So in this area, the highest areas of the airways. And as a result, if the secretions or the irritant material that we have in our airways is in lower parts of our chest, that means that we need to help that come higher so we can cough it up. And the way to do that is through the airway clearance techniques. And there's a great variety of different techniques and devices that we have. We know what was the traditional chest physiotherapy, the postural drainage, where we were using gravity to assist the secretions to come higher and towards the mouth. But we also have the manual techniques, like the percussion, vibrations that the physiotherapists were practicing on the patient chest to help with this mechanical force, the secretions to come higher. And we now have more independent methods as well, like the active cycle of breathing techniques, the autogenic drainage, and so on. And we have a great variety of airway clearance devices, positive expiratory pressure devices with oscillation or without. I'm not going to mention specific techniques or devices because at the moment we don't have evidence that one is better over the others. So the way you choose, it depends on other reasonings. And we know from the clinical guidelines that we have from the European Respiratory Society, British Thoracic Society, the Spanish, the Australian and New Zealand, and so on, that the quality of evidence we have about specific airway clearance techniques are actually quite low. So that means that we haven't still proven with strong evidence that a specific airway clearance technique works. But we know from previous studies that airway clearance techniques are better than nothing or just coughing. And in this map, I will just highlight to you that depending on where you live, having a respiratory condition means that you can be treated differently. So if you have bronchiectasis, for example, and you live in the UK, this means that you are more likely to get active cycle of breathing techniques over another method of airway clearance. So this is the way how we treat patients at the moment. And we have set up a European Respiratory Society task force with Beatriz Herrero Cortina, where we actually, with a big group of experts, and we have a pleasure of having 2 patients as well within this group, we are going to investigate and see what's currently happening in this area of airway clearance and see what we need to do in terms of education and research. So what are my take-home messages for airway clearance is that it is a standard treatment at the moment, and there is a variety of techniques that they seem to improve the quality of life, cough and sputum volumes in patients with bronchiectasis, but we don't have robust evidence to prove that. So if you're a patient, you need to seek respiratory expertise, you need to see a physiotherapist where you can decide together an individualized program and a technique that is suitable for you. And also this is important because we know that coughing is not enough. As I show you, you need to bring the secretions higher so you're able to generate a cough. So I'm going to move on to my next question then and ask you if people with bronchiectasis can exercise. Do you think they can as everybody else? Or do you think this is a joke? Because having bronchiectasis means that you feel exhausted and you cannot even think about it. Or is this something that people with bronchiectasis should consider as it will help with their condition? What do you believe at the moment? Okay, so most of you think that you should exercise and this is going to help you.
I think we may have unfortunately lost Arietta, so perhaps we can go back to the chairs.
We can maybe already start with while we are trying to reset the connection with Arietta, maybe a question for Josje in the meantime. Often patients say, or we have a question that patients say that they have quite a lot of symptoms of cough and shortness of breath. But when do they, or when, or what triggers should they be aware of to think about exacerbation? So where is the tipping point of daily normal symptoms and having an exacerbation, in your opinion?
Yeah, I think that's a really good question, and it's a question that many patients ask me. And as many questions that Peter has asked me across these years, it's a difficult question. And there's also a lot of research ongoing about how to better know that patients have an exacerbation in order to guide treatment. But before we have that kind of treatment results, I think the first point that's really important is that each patient and each doctor. Oh, you still hear me?
Yeah, we hear you. Just
that each patient and each doctor should be aware of their own daily symptoms And only if there is, like I tell my patients, a true increase in multiple symptoms, so that can be an increase in cough, exercise, or a decrease in exercise capability, or an increase in fatigue, if more of your daily symptoms are increasing in severity, then this could be an exacerbation. But it's quite hard because it's different for each patient, and it's sometimes quite subtle.
And so I think there's quite recently, Megan Crichton has developed the BEST score, which is trying to evaluate with the score system at what point we can expect an exacerbation. And in that same way, I would ask you, we have a question of a patient saying, well, I have quite a lot of fatigue, and so exercise seems to be something good, but then exercise really shortens my breath, really puts me down and increases my risk of having an exacerbation. How can we manage this? Are there any other things that we can do to try to avoid or try to find that balance, in your opinion?
Yeah.
And is it advisable to do exercise during an exacerbation?
Yeah, I advise my patients not to do exercise during an exacerbation, but to keep doing or even increasing their treatments for mucociliary clearance. Those are really important, but I do not advise my patient to go extra to their physiotherapist or to do daily workouts when they have an exacerbation, because the body needs the energy in order to fight the exacerbation itself. Yeah.
You are the azithromycin expert as the bacterial leading author. I have some azithromycin questions. So some patients say, I had to stop my azithromycin due to gut problems, or I couldn't cope with the treatment because it was too heavy on my stomach. What are the alternatives?
Yeah, there's quite a lot of patients who find macrolides hard to digest. They either get gastric problems or bowel problems or chronic diarrhea from them. What really helps is in my opinion, is to reduce the dosage. So instead of taking daily dosages, you can take alternating doses on alternating days. That sometimes really, really helps. I even have patients that I give macrolides to every second day. So I have 2 days between, and I think this really makes sense because of the very long half-life of macrolides. So in some patients, this might be convenient. I'm not a fan of other macrolide treatments instead of azithromycin. So in my opinion, erythromycin or clarithromycin have even more side effects and are less well studied. So we don't really know what the effects would be. But in my opinion, if you have doxycycline sensitive pathogens, doxycycline could be an alternative to macrolides, but it has been less well studied. And we don't know if it has all the same effects as azithromycin does.
I do thank Dr. Spinou for the chest clearance and exercise techniques that she explained so clearly. So if you still have questions for Dr. Spinou, put them in the Q&A box below, and if we can get back to her, we will do. But if not, they'll be answered as written answers on the website. So now I'd like to tell you about how I deal with my own self-management day to day. I've had bronchiectasis since early childhood. I had surgery to remove a lobe of my left lung at the age of 13, which gave me about 15 years good health. But the bronchiectasis came back in my 30s, and I've been dealing with it ever since. I joined the ELF patient advisory group in 2016 because I realized that bronchiectasis treatment had barely improved since I was a child in the 1960s. I'm a journalist, and I wanted to help raise the profile of the condition that's been neglected for decades. And I'm really pleased that we're now seeing very hopeful progress among the medical profession and researchers. I'm now in my late 60s, and I'll just tell you about my day. Before I do anything else, before my shower, before breakfast, I do an hour of exercise. This isn't particularly virtuous. It's just that if I don't do it when I first wake up, I won't do it at all. I use a yoga mat for core exercises and hand weights to strengthen my arms, my back, and my shoulders, since I'm conscious that my cough makes my shoulders hunch. I also do lung exercises, which I found on YouTube, and I march and I jog on the spot to build up stamina. I produce a great deal of mucus every day, and it really builds up towards late morning, about now. So that's when I use a nebulizer. It's one that was lent to me by the National Health Service, and I deep breathe hypertonic saline to loosen my chest every morning. You can see the weight of this nebulizer. It's very big and heavy, and it's too big to take traveling. Having said that, if you're nebulizing antibiotics, say on a business trip, you have to take it with you, which can be a pain and problematic with different voltages. You can buy portable nebulizers, but I found them very expensive, fiddly, and inefficient. So before lunch, I do my first chest clearance of the day on the sofa bed that you see there. I use a combination of postural drainage so that gravity helps and the active cycle of breathing. Hanging over the end of the bed with my head on a cushion and my chest on a slope, I turn over to clear both sides, my back and my front, with deep breathing, huffing and coughing. I do the same in the early evening so that my chest has time to settle before bed. In total, nebulizing and chest clearance takes about an hour a day, in addition to the hour's exercise. And that's a lot to fit in, especially if you have a full-time job and family to look after. When I was working full-time, I would try to do some chest clearance in the toilets at lunchtime, which is a bit embarrassing when workmates can hear. And it's a similar problem when you're traveling, having to find time and space to clear your chest in public toilets when people think you're conking out in the next cubicle. So you can understand why many people have problems sticking to a daily exercise and clearance routine. It's quite a burden in time and effort. It's doubly hard if you're on nebulized or intravenous antibiotics, which are very time specific and equipment heavy, and courses can last for months. We want to be active and lead life to the full, and we need treatments that are easier to take. I do chest clearance every day because I see the benefits. I couldn't manage without it. I know if I didn't do it, I would quickly feel ill. The mucus will build up and breed infection. My routine gives me the feeling that I'm in control of it rather than it controlling me. It keeps me stable and allows me to get on with enjoying life. I very rarely get exacerbations, although for a long time I have been colonized with Pseudomonas. So I do take a daily low dose antibiotic, the macrolide antibiotic, azithromycin. But now, if you want some real inspiration, here's someone who overcame childhood bronchiectasis to reach the heights of musical success. May I present a young man called Ben Goldscheider. Ben is a British professional musician, and he has played with orchestras across Europe. He won the BBC Young Musician of the Year competition in 2016, and I think he's an inspiration. If we could have the video, please, Jeff.
My name is Ben Goldscheider. I'm a classically trained French horn player, and I have been living with bronchiectasis for the majority of my life. I was diagnosed with the condition when I was 6 years old, and at the time my lung function was only 50%. So I guess for a young athletic person, that was quite a debilitating idea. And it was the advice of the doctors, really, that alongside a lot of sport, that perhaps taking up a wind instrument, an instrument that involved training the lungs, training the breath, would be a really interesting and beneficial way of managing the disease myself. I was doing physiotherapy 3 times a day, with a heavy reliance on parents and grandparents. I remember looking forward more to certain members of the family doing it, depending on how rigorous they were with shaking the side of my lungs. And I took antibiotics 3 times a day for about 7 years. I remember many, many nights, especially, where I would just relentlessly cough. But eventually, the treatment, my work with the instrument, my work with sport, and diet as well. I was very conscious of what I ate, and just generally to have a strong immune system meant that at the age of 13, I was actually formally discharged from the hospital, and since have, touch wood, had very, very few problems with my lungs at all. And I would actually consider myself perhaps to be much stronger physically, and certainly with my lungs, than if I'd never had the disease in the first place, because I perhaps would never have tried to work so hard with them. I spend my time now traveling all over the world, to Europe, North, South America, Asia, and I've been very fortunate with the experiences that I've had. If there was any advice I could give, or personal experience that helped me, it's that we really can do a lot ourselves if we dedicate ourselves to it. And I think that having this conference today is a remarkable way of bringing people together who share these experiences, who've had these thoughts, and hopefully exchanging ideas. And I'm really delighted to be part of it. I commissioned a composer to write a new piece for this album, Roxana Panufnik, and it turned out that at the recording session, I must mention that we'd never met before, it came up that I had bronchiectasis. And she remains to this day the only person on planet Earth that's responded with, "Me too." And so I'm really very, very happy to be talking to you virtually today at a conference which aims to create more connections like this, so we know more people with the condition, we can help from whatever experience we've had. And it's with that I really wish you all the best. And I hope that perhaps we can see each other at a concert one day.
Oh, thank you so much, Ben. I'm so impressed by what you've overcome, and may you go on to achieve even more musical success. Do put your questions to Ben or any of us in the Q&A box below. Now, I'd just like to run over the interim results of a current patient survey carried out by the ELF and EMBARC. The researchers wanted to find out the difficulties many patients face in receiving the correct diagnosis and the best care, including how to perform regular chest clearance. The survey went live in November 2020, and so far, 668 patients and carers have responded. 82% are female, 57% are age 55 or over. 26% took 10 years or more to get a diagnosis, and 26% were misdiagnosed with asthma or something else. Next slide, please. 56% found that their primary care condition lacked understanding of chest infections. 49% had difficulty getting their sputum analysed when infected. 93% had a productive cough, but 30% had no chest clearance advice or instruction. Next slide, please. The conclusions so far are that delays in diagnosis and access to proper care are common. There's a need to improve education in primary care, and we need improved access to specialised respiratory therapists to teach us airway clearance. And the final slide, thank you. This survey closes on March the 7th, so there's still time to fill it in. It's there in a variety of languages on the link being shown, or you can scan the QR code. The link is www.surveymonkey.co.uk/r/airways clearance. Now, as Ben demonstrated, music is wonderful for lifting our mood, and we often find that there's a link between our mental and physical health. Our next speaker, Dr. Anna Spathis, specializes in helping patients to overcome fatigue and breathlessness, using mind-body techniques to break vicious cycles. Dr. Spathis lectures at the University of Cambridge and is lead consultant for the Cambridge Breathlessness Intervention Service. Over to you, Dr. Spathis.
Thank you very much, Barbara. I'm just going to share my screen now, and before I get going, just want to check that you can see full screen and can see me. Barbara or Peter, is it working?
Yes, it is, Anna.
Fantastic. So yes, thank you very much, Barbara, and I'm so grateful to you for asking me to be here. In fact, I feel very honoured to be in this amazing event. So I'm going to be talking about mind-body approaches for the symptoms of breathlessness and fatigue. Josje Altenburg was talking about how common symptoms are, and Barbara also in the survey you were presenting it showed how common they are. We're going to move on to thinking about a symptom-focused approach, actually treating the symptoms, using the mind and body together to improve health and well-being. So let's start with a difference in perspective. Health professionals tend to have a disease focus. They're thinking about inhalers, steroids, antibiotics, of course. But then if somebody's still breathless or really tired with fatigue, it can get tricky if that disease, the bronchiectasis, has been as well managed as possible. So health professionals are thinking about patients with disease. Whereas we all know, you all know listening, it's not so much patients, people. We're all people, humans, not experiencing disease, but experiencing symptoms. So rather than patients labeled by disease, we're people experiencing symptoms. And these quotes in the dark orange give you a sense of what I think is probably familiar to many of you, that sense of being out of control. Barbara had mentioned that, and feeling helpless with these symptoms, perhaps frightened. And let's not forget family carers as well. Here's another quote. He says he can't breathe, but he has enough air to yell at me. Living with breathlessness is hard for everyone, people and their families. And this difference in perspective, this matters. There is only a weak link between the lung disease severity and the experience of symptoms. So, for example, some of you listening may have mild bronchiectasis but experience severe symptoms. Others may be severe bronchiectasis but happily only mild symptoms. But the importance is that as health professionals, we're focusing on improving the disease medically, but the symptoms are often bad or perhaps even worsening. So why is there this disconnection between the severity of the disease and the experience of the symptoms? I'm going to start off in this talk talking about breathlessness, and then we'll move on to fatigue. So I'm going to now share the first of 3 short video clips to try to explain this discrepancy. This first one is a couple of minutes. Hopefully the volume, the sound is working. If it doesn't, please yell.
Living with breathlessness is hard. It makes every day a challenge. People trying to cope with breathlessness desperately want it to go away. But here is the problem. Even with the best possible treatments, many people still feel breathless. Sometimes even when the disease causing the breathlessness is stable, the breathing keeps getting worse. It's almost like the breathlessness takes on a life of its own, separate from the lung or heart problems that caused it in the first place. So why does this happen? The answer seems to be that vicious cycles develop, which make the breathing feel even worse. The breathing, thinking, functioning model is a helpful way of thinking about breathlessness by showing us the three main vicious cycles. So, what are they? When people are breathless, the natural reaction is to try to take big breaths into the upper chest. This leads to people panting with tense shoulders. It makes the breathing inefficient, making it feel even harder and more uncomfortable. A real vicious cycle. Another normal reaction to breathlessness is to feel anxious. Breathlessness and anxiety often come hand in hand. Frightening thoughts like, "Is this my last breath?" can rush through the mind, but unfortunately this fear actually makes the breathlessness feel even worse. This spiral of breathlessness and fear can sometimes lead to panic attacks. The third vicious cycle involves another natural reaction to breathlessness. It's such an unpleasant feeling, people try to avoid it by moving around less. Sometimes people can think that making themselves breathless by doing things might actually be harming them. Family and friends try to help with the chores, so there's even less need to move around. But the problem is that being less active makes us less fit, and of course being less fit makes the breathlessness worsen even more. So what's happening here? The normal and natural reactions to feeling breathless are in fact making the breathlessness even worse.
So here are these three vicious cycles that we've been, or vicious circles that we've been talking about in that video. They're vicious circles of the normal instinctive responses. I really do want to make it clear that it would almost be strange if these responses weren't happening. It's nobody's fault. They are normal. And these feed back to actually worsen the underlying symptom. So let's just go through these quickly again. So the thinking spiral there is when our thoughts and fears, it's hardwired in our brain that it makes the breathing feel worse. Because we're breathless, it's hard to be active, we become less fit, and that in turn can make the breathlessness worse. And then finally, when we're thinking about our breathing or feeling frightened by it, it's easy to breathe inefficiently with panting breaths in the upper chest. And that in itself makes the breathing harder work and makes the breathlessness worse. So Jess, if you wouldn't mind just launching the poll, have a think about those three vicious cycles. And I'd like you to think about which of them feels most relevant to you, or perhaps to the person you're caring for. And you can choose any number of them or tick none of them. So I'll just pause a second while you do that. I'm curious to see your responses. I've never asked as many people as this all at once. So if it's possible to see the responses so far now. Oh, that's really interesting. So it's all pretty close. Breathing and thinking really resonate with you. I'm picking up, and functioning is up there as well. And for some of you, 16%, none of them, which is great. So I'm going to think now with you, how does understanding these vicious circles help us? So another short video now.
Suddenly things can begin to make sense. It's not just about the lung or heart disease, It's about the vicious cycles making the breathing even worse than it need be. Although vicious cycles are frustrating because they can make things worse, they can be broken. What's more, it's often only a small change that's needed to break it, flipping it over into a cycle of improvement. So a small change has the potential to make a huge difference. Understanding this can be motivating as it shows that something can be done about the breathing.
So just to paraphrase what I said there in the video, but explains in a bit more depth, understanding this helps explain that disconnection between the disease and the symptoms. It's almost as if the symptoms do take on a life of their own. I want to make it clear that we do need to, the starting point has to be managing the underlying lung disease, the bronchiectasis, as well as possible. But alone, that is often not enough because of the vicious cycles spiraling the symptoms and making them even worse. So for example, when we can treat an infection when it's really bad and the lungs are getting better, but after that trigger, the vicious cycles spiral off and keep the breathlessness going worse than it need be. The second thing is that there are positive messages from this understanding because we can break vicious cycles and we can help the breathing even when, for example, there may not be other disease treatments, other bronchiectasis treatments available. And as it showed in the video, a small change can make a big difference when you turn a vicious cycle into a cycle of improvement. And thirdly, and importantly, this is where the mind-body approaches come in, because they work by breaking the vicious cycles. And in this third video, I'll just cover some brief examples.
For people experiencing breathlessness, one of the vicious cycles tends to be the most important. If in the breathing cycle, it can be so helpful to understand that it's not necessary to work hard to take big breaths in. Instead, it may help to focus on breathing out, relaxing the upper chest and shoulders. When there's a lot of fear and anxiety, it can be good to talk through the frightening thoughts and learn ways of relaxing the body and mind. And for people who have become less active, it's important to realize that becoming active again will help the breathlessness as well as general health and well-being.
So there was an overview of some mind-body approaches there, and I'm in the next 3 slides, one for each of the vicious cycles, just going to give you a few more practical examples. There obviously isn't time to go into this in depth, but I'm going to try and give you ideas that can be quite quick. So thinking about breaking the breathing vicious cycle, simply changing our understanding can make a difference. Understanding that when we're feeling breathless, it's natural to think you need to take more air into one's lungs, but in fact this isn't the case. Particularly when there's some airway obstruction there's plenty of air in the lungs. Try lengthening the out breath instead, like when you're playing the French horn or singing, and this makes the breathing more efficient and makes space for the next breath. We often in our breathlessness service teach this 3F breathing technique. Facial cooling, so cooling the face with those little handheld fans. There's good science why cooling of the area around the nose and the mouth can reduce the feeling of breathlessness. Forward leaning, which many of you will know if you do experience breathlessness, can really help. And focusing on lengthening the out breath rather than the in breath a little more each time you breathe out. I've given you some other examples there, and just want to highlight, as we were having a musical tone before my bit now, about music, singing for breathing. In the UK, there are many singing for breathing groups. Even English National Opera has started one recently for people post-COVID. This is wonderful, and singing, of course, prolongs the out-breath like speaking, as well as being very relaxing. And people find it very helpful. Of course, playing a wind instrument or a brass instrument like Ben does would achieve the same thing, but singing is probably more feasible with less practice than Ben has undoubtedly done over the years. Breaking the thinking vicious cycle now. So here, again, the explanation alone for many people can be can be helpful. Many people instinctively feel something bad might happen when they're breathless, but although that's understandable, with the normal day-to-day breathlessness, this tends not to happen. And that realization can be so valuable. We find that, and I don't know what you all feel, but that using a relaxing image can be really helpful way of calming things. And the sea can be very good. If you think and visualize the sea, and your in-breath is that short wave coming up onto the beach, and then your out-breath is the long, soothing wave moving down the beach and returning to the sea. And many people find that helpful. And then finally thinking about breaking the functioning vicious cycle. I'm aware that we lost Arietta, who was talking about this, but just briefly to say that, again, it's important to understand that choosing to make yourself moderately breathless, I'm not talking about overdoing it, but moderately breathless by being active, is not harmful in itself. In fact, it'll build up muscle fitness, improving the breathing, therefore, and of course, one's general health over the coming weeks and months. And we often work with the people we're looking after on a walking program. It's so simple. You can use an app on your phone to count your weekly steps, measure them during a normal week, and then each subsequent week, just increase by no more than 10%, so 5 to 10%. And that gives you a very slow, steady increase, but you can see the improvement, even though it's slow because your steps change. And over 8 weeks, if you do the maths, one's activity has pretty much doubled without one noticing it. And I noticed in the chat and the questions, many people were talking, as well as about pulmonary rehabilitation, which is obviously well evidence-based, about yoga, Tai Chi, swimming. All of these are activities that also involve relaxation and managing the breathing. And for people with quite bad breathlessness, one can get out and about by leaning, for example, in the shops on a shopping trolley. I've looked after people with really bad breathlessness who are still able to use a bicycle because you're in a forward-leaning and efficient breathing position there. So we're not talking about formal exercise necessarily. We're talking about being active and doing the things one wants to do. So in my last couple of minutes, I'm just now going to move on to talking about fatigue. And I also saw in the chat that many of you have been talking about how bad fatigue can be. Essentially, it's the same principles, different vicious cycles, but the same principles of these vicious circles of instinctive responses inadvertently feeding back and impacting on the fatigue. This diagram comes here actually from some research I did with young cancer patients who were very fatigued, but we know that this is applicable across many, many diagnoses. So just to go through this quickly, that sense of frustration, anger, feeling low, thinking about how nobody understands how bad fatigue is because it's invisible, all that tension, even of the muscles, can make the fatigue worse. When one's fatigued, it's harder to be active, and that of course leads to that spiral we were talking about with breathlessness, about getting less fit. And many of you will find this familiar. It's certainly something I battle with quite a lot, is that as soon as one worries about one's sleep or gets really tired, then that can actually impact on how one sleeps. You can end up having little naps in the day, which impact on nighttime sleep, or perhaps when you're awake at night using electronic devices, which of course produce blue light that also impacts on sleep, and in turn come back and impact on the fatigue. So this spiral, it's a vortex, a word I heard you mentioning before, can make the fatigue get worse and worse, irrespective of what the underlying disease is doing. So finally, how can we help the fatigue? It's again by breaking these spirals. Helpful sleep habits make a remarkable difference. In our research, simply setting a regular going to bed time and a regular waking up time can make a big difference over weeks to the quality of one's sleep. building up activity, as we were discussing, is important because it breaks that activity vicious cycle. But of course, it's hard with the fatigue. And some people find that these 5 Ps can be helpful with building up activity, doing things more differently, planning one's activity, spreading things out by pacing over the day, and prioritizing the most important things. So bringing this to an end, just with a couple of summary slides. What have we said so far? Mind-body approaches are effective in parallel. I want to emphasize that, in parallel with treatment of the underlying disease. So even when people are saying, look, there's no more that we can do medically for the bronchiectasis, you're on all the treatments, by breaking the vicious cycles, there are still things that can be done to help. And I also just want to make the point that actually these mind-body approaches in turn can feed back and help the underlying lung disease. Exercise, relaxation, these are well known to be anti-inflammatory, helping the rather different vicious cycle that Josje was talking about before, that of what happens within the lungs. Exercise, of course, can improve chest clearance, so it can work both ways. It's a positive approach where something can be done. And interestingly, the thing we do is often not focusing, paradoxically, on the symptom itself. For any of you experiencing severe breathlessness, you probably know that particularly if you're worried by your breathing, focusing on the breathing actually can make it feel a bit worse. We're thinking about other things, being active, relaxation, and so on. And finally, and really importantly, these approaches don't involve drugs. They're simple and safe, and they can fit into daily life. I'm a huge advocate of walking in nature. It achieves all those things that we're talking about, as does singing. It's active, it's relaxing, and also, particularly with the singing, can help with the control of the breathing. I would say that these are life-enhancing. This is what people say. So what's next? Well, many people say to me, why can't health professionals focus on my symptoms? Why is it always about the disease? Now, of course, health professionals like myself do focus on the disease because they're hoping to help the symptoms. But when it doesn't help the symptoms enough, we do need to take symptom-focused approaches, thinking of these vicious circles, as I've been discussing here. And I think we need to educate health professionals, and that's something I take very seriously. I teach medical students and other students a lot. We're developing an app which is getting ready, but there's still a bit more work to do, and other resources to support people to look after themselves with these approaches. And research is underway in the UK and in some other countries. And we are planning further research as we speak. So overall, although we may not always be able to change what's happening in the lungs, what we can change, what we can take control over, is how we think, feel, and behave. And making a small change to these instinctive natural reactions to breathlessness and fatigue that feed back and worsen the symptom, we can make a big difference to these symptoms and therefore to our well-being as well. And this is so important, as many of you know. And a lot of this, as Ben and Barbara were saying, are things that we can do ourselves to help ourselves. So thank you. That's it from me. And I'll pause there because I think we're moving on for questions. Thank you all very much for listening.
Thank you so much, Dr. Spathis. That's really helpful, because I think very often the mental aspect of our condition is overlooked. And we're really grateful for your encouragement and support and advice. So that's fantastic. Thank you. If you've any questions for Dr. Spathis or any of us, put them in the Q&A box. I think we may be able to go back to Dr. Spinou, who was cut off towards the end of her talk. So is that possible? There we are.
Hello, and massive apologies. I had a problem with my internet connection. Very sorry, I couldn't finish my presentation earlier. If it's all right with you, I can share the rest of the presentation now. So.
Dus met dat bakje bezig aan dat stopcontact. Hè.
So I think some of the parts I wanted to discuss with you have already been covered from the other people of the panel. So I was going to say why exercise is important, even if you feel exhausted. And I was going to mention this vicious cycle. When you feel breathless, you avoid the activities that make you breathless, and then you do less. And this makes you even weaker and less efficient, and you become breathless much easier than before. And then it goes round and round. And that is why exercise is important. And we know that people with bronchiectasis can benefit from pulmonary rehabilitation. So what is pulmonary rehabilitation? These are classes. It's a program that runs classes for people with lung conditions, and they go to a community setting usually twice a week, and they do some exercise by themselves once a week. And they do exercise together in a group, and they also attend some educational sessions where they talk about how to manage their condition. So things like what you should eat, or how to set goals for your exercise, and how to manage your airway clearance if you need to review that. People who are running the pulmonary rehabilitation classes can help you with that. And it is important to mention that we have very strong evidence that pulmonary rehabilitation is beneficial for people with bronchiectasis. So most of the clinical guidelines we have, they recommend people with bronchiectasis to attend this program. So if you attend pulmonary rehabilitation, keep in mind that you can increase your exercise capacity, which means that you might feel less breathless or less fatigued than you were before for the same activity. There is a trend for improving quality of life and the exacerbation frequency, so how often you feel unwell. And there is some evidence that it might actually extend the time that you feel well before you have another exacerbation. And we know that there is no adverse events from exercising with bronchiectasis. So very sorry that you didn't manage to watch the full presentation at once. It was just a very quick whiz through into airway clearance, what we have available, and why we need to do airway clearance, and cough is not enough, and also why we need to exercise. It's more about getting you into thinking that you should contact a specialist or someone who can help you in your area and discuss different options. I know that lots of you from the questions and answers, you have specific queries about airway clearance techniques, specific devices, for example, or specific methods. But these kind of things is better to discuss with someone who knows you, and they know the severity of your condition, your daily living, what you can fit into your activities, and so on. So thank you very much, and sorry for that. I will be happy to discuss further about this presentation with you.
Thank you very much, Dr. Spinou. I was very glad that we were able to get back to you for the end of that talk, because I'm a firm believer in the importance of chest clearance and exercise. So now I think we're going to be able to go to your questions and answers. So Peter, would you like to forward some of the questions to our speakers?
Yeah, sure, absolutely. I'll start my video first. So Arietta, we have quite a few questions for you. There are two questions on percussive vests and why they are so popular in the US, and why for some reason in Europe they are almost never used.
So yes, we know that there's many differences in the way we treat bronchiectasis between the United States and Europe. Specifically for devices or machines like the vest that they can be used, and we know people use a lot in the US. I think it's mainly a difference in the culture of how we approach airway clearance. So, for example, in the United Kingdom, we have the British Thoracic Society guidelines for bronchiectasis, where we have a stepwise management, and we start with techniques that the patients can practice without any support. They can be independent, and we move forward to other devices if we need extra support or something stronger and let's say more aggressive. It also relates to what the insurance covers and what is available and the cost, of course. But I think it's mainly a matter of how we want the patient to get their independence and self-management in different areas. So in Europe, we try to promote things that they can practice independently without any devices. If we see this doesn't work, then we go into other techniques.
There's thank you for your answer. There's one question of someone who is concerned that by coughing too hard or too much you can damage your lungs and your throat. Could you answer that question?
Oh, that's a really good question. Too hard, too much of airway clearance, do you mean? So if you cough a lot, if you cough because you have secretions and not as a part of your airway clearance, we know that you might cough very strongly and you might even have a fracture, so break one of your ribs or even vomit from coughing. When you use airway clearance, we try to promote huffing instead of coughing, so the technique is slightly different. So it actually protects the way you are performing this forceful maneuver, and it doesn't have this anecdotes of side effects, because it's much more gentle and it's also more effective. So that's why it is important to practice something which is aimed specifically for airway clearance, and use a technique or device that you have discussed with someone who knows, as a physiotherapist, or depending on the area you live, it might be a nurse or it's even chest physician, depending on the services of your national healthcare system, rather than trying to do only coughing by yourself. And we also know from the evidence that airway clearance, different types of airway clearance techniques are more effective than coughing alone or nothing, or doing nothing.
There's one.
So don't be afraid to do airway clearance. The only reason to stop is actually when you get tired and you cannot continue this. If you feel that your chest never gets clear, then at some point you will need to stop. You might get tired from that. It might not be feasible for you to continue, and that's fine. So if you feel clear, then you stop, or if you get tired and you cannot clear your chest, then you stop. If you have this constantly, you cannot clear your chest completely, you need to discuss it with your physiotherapist. You might need to review your technique.
There's, as you mentioned, stopping. I have a question from a patient who has said that in the beginning it worked. I used to produce a lot of phlegm, she says, and a lot of cheering. This is very annoying that the questions pop away when some people ask new questions, sorry. So I currently produce a very small amount of very sticky white phlegm, and I'm able to get rid of it every other day. Should I still be persevering with chest clearance, or is it okay to miss it at the moment, or to maybe tailor it down?
So if the phlegm becomes more sticky, it might mean that you need to also visit some kind of technique that for hydration, or you need to drink more water, or you need to use some nebulizers. If you cannot cough up phlegm because there is nothing there, it's fine to reduce the times that you perform that. And actually, not all the people with bronchiectasis have the same regime of airway clearance. We don't have a specific guideline for 2 times a day or every day, or it really depends on the severity of the disease and on the person we have in front of us. What is important is actually to see if that's a genuine reason why you cannot bring up the phlegm. If the genuine reason is that there's nothing there, or it is that it is very sticky. So it's very different, because if it's not there, then it's fine to reduce the times you do your airway clearance. But if it becomes more sticky, it's actually an indication that you might need to do it more frequently, or you need to change your technique, or look at the options of hydration and saline and so on.
Okay, thank you. I have a question for my co-chair, Barbara. One patient asks that sometimes when she's out in public, she gets embarrassed when she starts coughing or feels like coughing up phlegm. Do you have any tips or tricks in order to cope with that, or to easily get by this problem?
Not really. It's just a case of trying to be as discreet as possible. And I never go anywhere without tissues and plastic bags. To be honest, I take nappy bags everywhere I go, and they're very useful because they're waterproof. They don't leak, and you can dispose of them pretty easily. But there's no easy answer to the need to cough, I'm afraid, in public. It can be embarrassing, but you have to do it in order to carry on with your life. So you just do it, and it doesn't matter. People don't care about you.
Okay, thanks. Maybe a question for Dr. Spathis. When would you prescribe, for example, yoga? We've seen a lot of yoga in the comments. A lot of people do yoga. How does it position itself in that triad that you have described, and who would be the ideal person for yoga, or would you recommend it to everyone? And who would benefit from singing, who has the walks, because you can't do them all, I think, because you have other chores that you need to do. How would you, from a practical point of view, advise these interventions?
Thank you, Peter. I think it's really about personal preference. All of these approaches can help one or more of those vicious cycles that we were talking about, and they're good in their own way. It's what you enjoy, and then they can be adapted according to your own situation. So, for example, I was looking after somebody with really severe COVID-related breathlessness recently, who was not moving around, barely didn't leave her bedroom actually for 3 months, and she was able to online, yoga therapist joined her, and she from her bed was doing yoga breathing and relaxing, and then gradually over time was able to build it up. And it's the same with singing. One doesn't need to be advanced singer, just wants to use one's voice, and then one can just do it in one's own way. In this new virtual world, you can even turn the mic off and sing with virtual choirs. So there's no right or wrong, it's what people enjoy.
Okay, thanks. Coming back to Arietta, in these COVID times, do you have any recommendations for online pulmonary rehab during lockdowns? Because the community ones are often closed in certain countries.
Yeah. So at the moment, most of the services have turned into virtual pulmonary rehabilitation. I think this is fine for people who have already joined pulmonary rehabilitation and they've done it before, but it could be, I don't know how it could be for those who haven't been introduced to pulmonary rehabilitation and they start that virtually. it is what it is. So if the service runs virtually, this is the only option you have. I would still advise that people go and join this, and we just need to be patient until we get over this situation and we're able to join face to face again.
Okay.
I think it would still benefit those who have bronchiectasis, because it gives you the support, it gives you someone who can guide you to what you need to do in terms of exercise levels, how the intensity, if you're doing things right. And also it gives you the support system from your peers and the educational component where you learn more about your disease, like pretty much what we are doing today. You have people you can ask about your concerns, and you can get answers that you can rely on. And then you can actually see how you can best manage your own condition. And it's very important because this is a chronic condition. You're dealing with this every day. So I think that we need to empower people with bronchiectasis to get this ownership and actually fight this because they are the people in the best position to do that successfully.
Mm-hmm. For Dr. Spathis, someone asks, where can I find more information on the mind-body approach?
So it isn't just one approach, it's so many approaches. And each of these, depending on which country you're in, you'll be able to access information, a lot of information online. For example, from the British Lung Foundation in the UK, from the European Lung Foundation, yourselves running this conference. We are trying to produce, we've created publications, and we're trying to produce resources. We'll have a website up and running in the next month, where we're going to collect a lot of resources about these types of approaches, and the app will be accessible through that, initially with registration, but subsequently, once it's gone through another round of research, more freely available.
Okay, thank you. Maybe one for Josje. Josje, someone asks specifically to you if, in your opinion, weight loss could be the sole or the predominant symptom of deteriorating bronchiectasis.
Yes, I see in patients with severe bronchiectasis, I many times witness weight loss, and especially when they are running into an exacerbation. The weight loss can be a very prominent problem, and it's often quite difficult to get back to the original weight after having an exacerbation. This is not true for all patients. Some of my patients have the opposite. They have problems. They have a tendency to getting obese, but weight loss can certainly be a sign of an exacerbation or a decreasing condition for sure.
Okay. Arietta, I have some patients, actually quite a few patients who are very scared of doing the coughing and the physiotherapy because they are afraid of coughing up blood. How should we deal with patients who have intermittent hemoptysis, but just not enough to do an interventional radiology or to do something more invasive?
So in the cases with hemoptysis, which is not very rare in bronchiectasis, what we do from the physiotherapy side of things is we avoid using positive expiratory pressure or things that create pressure within the lungs, and we stick more gentle, if we can call them like that, more gentle exercises like active cycle of breathing techniques and so on. So it is a balance between the risk and the benefit. So if you have someone who has severe bronchiectasis and severe hemoptysis, it's not your priority to do airway clearance at that point. You try to manage the hemoptysis first, and when they're stable from this, then you can continue with the airway clearance. On the other hand, if you have someone who the airway clearance is absolutely the priority, you might actually try even more with airway clearance, even if you have bronchiectasis. I think this is important to be discussed with the medical team and the physiotherapist. So it's a decision that they will take together as a multidisciplinary team.
There are some healthcare professionals who want to ask you as well if there are any other contraindications besides hemoptysis for doing open glottis techniques, for example, or other chest physiotherapy techniques.
Sorry, could you repeat the question?
So there's a few physiotherapists, I think, who want to know, just aside from the hemoptysis, are there any other contraindications for chest physiotherapy? For more specifically, there's a lot of questions on the ELTGOL technique, the open glottis technique.
Okay. Okay. So for each specific airway clearance technique or device, there are contraindications or things that you need to consider when you choose. So it's a list for each one. As a generic rule, you can say that those that are the simplest one and they don't provide any external expiratory pressure. So if it's something that you practice like autogenic drainage or active cycle of breathing techniques, I won't answer about LTOG because I haven't practiced it with my patients and I'm not the best person to reply to that. But generally, you advise people to start with these, at least in the UK, that's what we are doing clinically. And those are those that they don't have so many contraindications. From what we know from the data of the studies is that airway clearance techniques are safe. So we don't have adverse events when they're used appropriately.
Okay, maybe one last question because we wanted to stop at 1:10 for Josje. There's quite some questions on the sputum presence, so we need to expectorate, we need to try to cut the vicious cycle, and they are asking for other ways in order to reduce the sputum. Do you have some suggestions besides physiotherapy? For example, the azithromycin data, which you know inside out, does it show that there's a reduction in sputum volume? Could you give some more information on that?
Yeah, I think the sputum volume is a really hard problem to tackle because it involves all parts of the vicious circle and all contribute to the overload of mucus that patients are experiencing. I would say that the most important tool in order to reduce the mucus problems are proper airway clearance techniques. And of course, and in addition to that, to treat bacteria or bacterial colonization if present. And in addition, we are looking for anti-inflammatory treatments, such as macrolide treatment. But I must say that in the studies I have performed about macrolide treatment, we haven't been specifically looking at sputum volume because it's quite demanding for patients having to collect their sputum for 24 hours each day. But we had some occasional reports and spontaneous reports from patients who said that they are coughing up less since they have started macrolide treatment. Mm-hmm. But I really think that James Chalmers in his talk about anti-inflammatories will also come across this subject.
Okay. We have, so Jeanette Boyd just told me we have time for one more question, and I'd like to close the session questions down with one more question for my co-chair, Barbara. And one person asks, could Barbara explain more how she nebulizes? I couldn't visualize her positioning on her couch, how she turns over. Also, is the big nebulizer not a problem for her? It really feels important to me to know how she does it.
Well, I don't nebulize at the same time as doing the airway clearance on the bed. I sit up and do the nebulizing. And then I do the airway clearance on the bed. Well, I can't really demonstrate to you now, but I lie on the bed with my head on a cushion and lie on first my left-hand side and clear that side, and then on my front, clear my front, then on my other side, my right, and then on my back. You do have to be quite fit to do it, actually. And it's not suitable for people who have acid reflux. It's not suitable at all. But I find that gravity really aids the production of the sputum. It really does help. And I really would like to have to do without it. I know possibly as I get older I'll have to, but at the moment I'm quite fit and able to do it. And combined with the active cycle of breathing, which is really, really heavy, deep breathing, and huffing, which is short, and then coughing as soon as you feel the sputum in your throat. That really works for me. It does clear my chest, and it makes me feel a lot better when I've done it every day, twice a day. So it's good to feel a lot better twice a day.
Okay. I'm not going to anger Janet too much, but one more question, because I really need to ask this question, because there's a lot of people asking questions about the relationship between the patient and their general practitioners who are reluctant to refer or reluctant to do certain tests or do not see the importance. How is your relationship with the GP? Could you give us some tips for the patients who have a difficult relationship with the GP, how to improve that, how to, maybe from a patient perspective, educate or stimulate your GP? Could you have some tips there?
Well, to be honest, with my GP, they don't bother me unless I bother them. They never do the annual review or checkup that they're supposed to do, simply because they're overwhelmed and they haven't time to deal with you on that sort of detailed basis. But if I go to my GP, they are quite helpful. They want to help. It's just that they don't know bronchiectasis as well as we do, as well as we patients do, I'm afraid. And also, it's difficult to get sputum analysis results quickly going through your GP. Results that can come through within 24 hours in a hospital setting take probably several days, 4 or 5 days, or if there's a weekend in between, it can be as long as a week before you get any results and before you're able to get on to the most appropriate antibiotic. So that is difficult. No, it's I would say it's a distant relationship really with my GP. Luckily, I don't have exacerbations very much at all, only 1 to 2 a year. So I'm lucky in that respect. Other people will probably have much closer relationships with their GP.
Okay.
But like many people, I haven't been able to see my specialist consultant, my respiratory consultant, for 16 months now, since November 2019.
Okay.
And they haven't been in touch with me at all. No.